Welcome to the Deep Dive. We're here to break down the latest, most important cardiology research.
Keeping you up to speed?
Exactly. Today, we're tackling a really significant state-of-the-art review on cardiac amyloidosis from JACC Cardiovascular Imaging, just published this year, 2025.
And we're doing this under the expert guidance of Dr. Caroli. You can find more at drcaroli.com. This review really maps out the incredible progress over the last 10 years.
It's called The Last Decade in Cardiac Amyloidosis: Advances in Understanding Pathophysiology, Diagnosis and Quantification, Prognosis, Treatment Strategies, and Monitoring Response. Quite a title.
It covers a lot of ground. It truly underscores how much our approach to this condition has evolved.
And for everyone listening, fellow cardiologists, primarily staying current with this is vital. This deep dive focuses on those big leaps in how we diagnose and treat cardiac amyloidosis, or CA.
Right, CA, where you get those abnormal amyloid fibrils building up on the heart muscle. It really messes with how the heart works.
We know most cases are either AL amyloidosis from misfolded light chains or ATTR amyloidosis from transthyretin proteins.
But the review points out we're getting better at spotting the rarer types too.
Crucially, though, no matter the type, it's the heart involvement that really drives the outcomes, the morbidity and mortality.
That's the key takeaway. Cardiac involvement is paramount.
Okay, so let's get into it. The review strongly argues that advances in cardiac imaging, multimodality imaging, have been absolutely central to all this progress.
Totally central. These imaging tools let us diagnose CA much earlier and more accurately too.
Which, is crucial for getting patients onto the right treatment pathways sooner rather than later.
Exactly. And imaging isn't just for that initial diagnosis anymore. It's changing how we understand the disease itself, how it develops.
Helping us predict its course.
Predict prognosis, yeah, and even quantify the actual amyloid load in the heart. That quantification piece is becoming super important now, with therapies aiming to directly reduce that load.
Before we jump into the specifics of imaging, just a quick reminder. If you find these discussions useful for your practice, please subscribe to the Deep Dive on Spotify and YouTube. That way you won't miss any future episodes.
Good point. Okay, back to the review.
Right. So it moves into diagnostics, focusing on how multimodality cardiac imaging has really stepped up. What's the first thing that grabs you there?
Well, it starts with echocardiography, our standard workhorse, right, for heart failure assessment. But it's become much more sophisticated for spotting CA.
We've known about the classic signs, the thickened walls, the stiff muscle.
Biventricular thickening, diastolic dysfunction, sure. But the review digs into the subtler patterns, the ones that should really make you think amyloid.
Like that specific pattern of deposition, base to apex, endocardium to epicardium?
Exactly. And how that affects contraction. Right. You often see the longitudinal function, the shortening and lengthening impaired early on.
While the radial squeeze, the inward motion, might look relatively normal until things are more advanced.
Precisely. Which leads into the whole apical sparing pattern of longitudinal strain. It's become a pretty well-known diagnostic clue.
Can you break that down quickly?
Sure. So normally the heart muscle shortens fairly evenly along its length. In amyloid, the base often gets hit harder first, so it doesn't shorten as well. But the very tip, the apex, sometimes keeps contracting quite well. That difference is the apical sparing.
Got it. But the paper cautions it's not specific, right? You can see it elsewhere.
Exactly. Aortic stenosis, CKD, other things can mimic it. So it's a clue, not definitive proof. That's pushed researchers to look at other echo measures.
Like the septal apical to base ratio.
Yeah, that ratio seems to perform a bit better diagnostically, especially when you combine it with other typical features of CA on the echo.
And beyond diagnosis, strain is also being looked at for tracking disease progression.
It is. But interestingly, the review suggests that maybe myocardial work index and efficiency, these measures that incorporate blood pressure, might actually be better markers.
Better for seeing deterioration and predicting outcomes.
Seems that way. They give it a more complete picture of how the muscle is actually working under load.
Makes sense. And people are developing echo scoring systems now, too, combining different metrics.
They are, trying to improve diagnostic accuracy. The usual challenge, though, is finding a single cutoff that gives you both high sensitivity catching the disease and high specificity avoiding false positives. It's tough.
And I saw mention of machine learning being used on echoes.
Yeah, that's definitely an exciting area. The potential for automated detection of CA from just standard echo images. Yeah. That could really help with earlier, wider identification.
Very cool. The review also brings up atrial involvement, amyloid in the atria.
Right. Something we're much more aware of now. Progressive loss of LA function, increased stiffness.
And that atrial electromechanical dissociation, where the electrical signal is there, but the atrium doesn't actually contract properly.
Exactly, even in sinus rhythm.
Mm.
And that's clinically important because it increases the risk of atrial thromby.
Even if patients are on anticoagulants, that's a critical point for management.
Absolutely. And the review also touches on valve issues, AS, MR, TR, often seen in CA, linked to worse prognosis, and the regurgitation tends to worsen over time.
So echo gives us clues about the type too.
Yeah.
AL versus ATTR.
It gives some clues, yeah. There are trends like maybe ATTR has more mass, more asymmetric septal thickening compared to AL, but honestly, there's just too much overlap.
So echo alone usually isn't enough to differentiate the amyloid type.
Generally, no. You need more information.
Okay, moving beyond echo, the review talks about SAP scintigraphy, serum amyloid P component. That's a nuclear technique.
Right. SAP scintigraphy is really good for quantifying the amyloid load in visceral organs, liver, spleen, kidneys. It's quite accurate there, especially after biopsy confirmation.
And this is key. It doesn't show myocardial infiltration, right?
Right.
Doesn't show amyloid in the heart muscle itself.
Correct. Its strength is outside the heart. It's also useful for tracking treatment response in those organs, especially in AA and AL amyloidosis. You can actually visualize the amyloid deposits shrinking as the precursor protein levels drop. There's a figure in the paper showing that regression.
Seeing disease regression in organs, that's powerful. Okay, let's shift to cardiac magnetic resonance, CMR. This seems like a real powerhouse.
It really is. CMR gives you structure and function like echo, but adds tissue characterization. That's the game changer.
Helping distinguish CA from other hypertrophic conditions.
Exactly. We use gadolinium contrast, look for those typical LGE patterns, late gadolinium enhancement, often subendocardial or transmural.
But LGE isn't really quantitative, is it?
Not inherently, no. But that's where multi-parametric mapping comes in. It's like getting multiple layers of tissue information.
Okay, tell us about mapping, native T1.
Right, so native T1 mapping measures myocardial relaxation time before contrast. It's often prolonged in CA, quite diagnostic in experienced centers, but it reflects a mix of things happening in the tissue. It's a composite signal.
And after contrast,
After giving gadolinium, we can isolate the signal from the extracellular space and calculate the extracellular volume, or ECV.
ECV, that's become a big one.
Huge. ECV essentially acts as a surrogate marker for the amount of amyloid sitting in that space between the muscle cells. It's a classic interstitial disease marker.
And the key is that ECV can go up early, before LGE or other changes.
That's the really exciting part. It's often elevated before significant structural changes or LGE appear, making it highly accurate for diagnosis. It gives us a number representing the amyloid burden.
Which helps track the disease, presumably?
Absolutely. Quantifying ECV helps us understand the disease process better. Different things go wrong at different ECV levels, like longitudinal strain might worsen at lower ECV values than, say, ejection fraction.
Why is that?
Likely reflects that early subendocardial infiltration pattern we talked about with echo. The inner layers important for longitudinal function get hit first. Figure 3 in the review illustrates this nicely.
ECV can also show differences between AL and ATTR.
It can suggest differences in how the myocytes respond, like apparent relative hypertrophy in ATTR that you don't see as much in AL. But again,
Overlap.
significant overlap. So even though ATTR might show greater mass, more transmural LGE, higher ECV on average, CMR alone still struggles to definitively separate the types.
Got it. But CMR is good for spotting liver and spleen involvement, especially in AL.
Very good. Routine CMR picks that up well. And liver spleen ECV measurements actually correlate nicely with SAP scintigraphy for detecting that visceral involvement. This impacts diagnosis and treatment choices.
What about T2 mapping?
T2 mapping is a marker for edema, or water content. It can be elevated in ALCA, possibly reflecting direct light chain toxicity, causing some inflammation or fluid buildup.
And stress perfusion.
Quantitative stress perfusion mapping shows really reduced blood flow reserve in CA, sometimes as bad as triple vessel disease. It correlates with the amyloid burden, and biopsies confirm infiltration in the small arterioles and capillary disruption.
Wow. So putting it all together, CMR gives you
A really comprehensive picture. Structure, function, LGE, plus mapping tells you about amyloid burden with ECV, edema with T2, ischemia with perfusion, the myocyte response through mass and ECV, and overall severity using LGE and ECV. It's redefined how we assess cardiac involvement.
Okay, next up. Cardiac scintigraphy with bone tracers. This has really taken off for ATTR-CA diagnosis.
Absolutely. It started somewhat serendipitously, noticing incidental heart uptake on bone scans back in the 80s.
Using those technetium-based tracers.
Right. Then came the key study showing 99 milli-TC-DPD could diagnose ATTR-CA based on visual grading, Perugini grade 0 to 3.
Yeah.
Figure 4 shows that. And other tracers like HMDP and PYP were found to work similarly.
But it's not just ATTR, right? Other types can show some uptake?
Correct. Mild uptake in rarer forms, and even up to 40% of ALCA patients can show some degree of uptake.
Which led to this specific algorithm for ATTR-CA.
Exactly, combining the scan result with tests to rule out AL amyloidosis, serum-free light chains, immunofixation.
And that was the basis for the non-biopsy diagnostic pathway.
Yes, the study showing that grade 2 or 3 uptake on the scan had incredibly high sensitivity over 99% and pretty good specificity, around 86% for ATTR-CA. Most false positives were actually ALCA cases.
And if you combine the positive scan with negative monoclonal protein tests,
The specificity jumps to basically 100%. But sensitivity drops a bit, maybe to 70%, because monoclonal gammopathy is fairly common in older folks anyway.
but that non-biopsy pathway, combining the scan and the blood tests, has been validated now.
It has in several studies. It's a huge step forward, potentially avoiding biopsy for many patients.
A definite win. But the review mentions some caveats still.
Yeah. Questions remain. How well does it perform in populations with lower disease prevalence? Or in milder, earlier disease that could lower the positive predictive value?
And certain hereditary TTR variants might not show much uptake.
Right. Some specific mutations, SIR77 tire, TIRE11-CZ, Phe64 LU are mentioned, can have significant disease but low uptake. So they wouldn't meet the non-biopsy criteria. You'd need gene sequencing and maybe CMR if you still suspect it.
And conversely, if the CMR looks like amyloid, but the bone scan is grade 0 or 1.
The vast majority turn out to be ALCA. So that combination becomes almost 100% specific for AL once you exclude those rare TTR variants.
So bone scans are way up now, different tracers being used.
Yeah, PYP often in the US, DPDH-MDP more in Europe. We assume they perform similarly, but no head-to-head trials yet. Technique matters too, acquisition, interpretation.
And interpretation has evolved away from just planar images.
Definitely. Planar imaging alone isn't recommended anymore by ASNC. SPECT is mandated, and SPECT-TCT is preferred
Why is that?
to reliably separate true myocardial uptake from residual blood pool activity in the heart chambers. Blood pool can look like uptake on planar images, a false positive. Figure 5 shows that difference clearly.
But the visual interpretation, done right, is consistent.
Yes, 99 milli-TC PYP visual interpretation shows excellent inter-observer reproducibility when using the recommended methods.
Does the amount of uptake tell us anything about prognosis or burden?
That's less clear. There's competitive uptake in bone and other tissues, so just how bright the heart looks might not perfectly reflect the total amyloid load. Grade 1 uptake might be an early marker in wild-type ATTR, maybe before structural changes.
And historically, the grade didn't seem to change much over time.
Right, in the pre-therapy era, the planar visual grade was pretty stable over 1.5 years, even with progression. But now, with TTR therapies, there's emerging data showing reduced uptake.
Even without major echo changes.
Exactly, suggesting maybe molecular changes in the fibrils, not just a reduction in mass.
So current research is looking at quantification with SPECT-TCT and AI.
Yeah, trying to get absolute quantification, maybe improve diagnostic accuracy for those borderline grade 1 versus 2 cases. Whether it tracks progression quantitatively is still uncertain. We need studies correlating these measures with outcomes.
Okay, last diagnostic modality, PET, positron emission tomography with specific amyloid tracers. Still mostly research.
Mostly research, yes, but very promising. Tracers like 11-CPP showed high accuracy early on, but need a cyclotron.
What about the 18F tracers? Like florbetapir?
Longer half-life, easier logistics. 18F florbetapir shows good colocalization with amyloid ex vivo and diagnostic utility in small studies. Tends to show higher uptake in AL than ATTR, but again, overlap exists.
And florbetapim.
One study suggested different washout kinetics. Maybe AL holds onto the tracer longer than ATTR, potentially helping differentiate them. Generally, most of these beta amyloid type tracers show lower uptake in ATTR compared to AL.
Florbetapir useful for early detection in AL, even RV involvement.
Yes, seems useful for detecting early cardiac infiltration, and the degree of uptake seems to reflect burden. RV uptake correlated with RV changes.
And whole body PE is an advantage.
Big advantage, especially for systemic AL. 18F florbetapir PT can spot extensive organ involvement, sometimes before clinical signs appear.
Then there's the newer tracer, 124I ivusamotide.
Right, a novel pan-amyloid tracer, binds multiple types, showed uptake in all CA patients in one study, maybe even better than florbetapir for ATTR, and correlated well with CMR-ECV.
And good for extracardiac organs, too. Any differences from florbetapir?
Yes, high-accuracy extracardiac. Key differences.
Hmm.
It seems to detect liver amyloid, which florbetapir doesn't do well, and might work for renal amyloid, too. Figure 6 shows some examples.
But bottom line for P tracers.
Promising for diagnosis, maybe prognosis, maybe even detecting disease before structural changes. But still investigational, not widely accessible or reimbursed. Need larger studies comparing them to established methods.
Okay, that's a huge amount on diagnosis and quantification. Let's take a breath. When we come back, we'll shift focus to prognosis. How do we use biomarkers and imaging to predict outcomes in CA patients?
Sounds good. Prognosis is critical, obviously.
Right. So stratifying prognosis. The review emphasizes that cardiac involvement is the main driver of how patients do, morbidity and mortality-wise.
Absolutely. So measures of cardiac amyloid burden are highly prognostic.
The most common approach uses serum biomarkers, right? These staging systems.
Yes, several widely used systems. For ALCA, there's the original Mayo 2004 system using NT-proBNP and troponin.
Then modifications like the European one, Mayo 2012, adding differential-free light chains, DFLC, and the Boston University system using BNP and troponin I. They define different risk stages. Table 1 summarizes these.
And for ATTR-CA, similar logic. There's a Mayo system, again, NT-proBNP and troponin. Then the NAC system from the UK using NT-proBNP and EGFR.
And an expanded NAC system adding a 4th stage based on those same markers. Again, Table 1 lays these out.
NT-proBNP is central to nearly all of them, but it's important to remember it reflects overall heart stress, not specifically amyloid burden. It's more of a final common pathway.
So imaging can add more specific prognostic information beyond the biomarkers.
Definitely. Imaging metrics can refine prognosis considerably.
What about echo parameters?
Longitudinal strain stands out. It's independently prognostic, even after accounting for biomarker stages, likely because it reflects that early endocardial involvement.
Makes sense. What else on echo?
Low stroke volume is a bad sign. Often low in CA due to systolic issues, the concentric remodeling, small cavity size. So index stroke volume is a good comprehensive marker. Myocardial contraction index, too, might be better than just EF.
And CMR tissue characterization must add prognostic value.
It does. The extent of LGE, specifically, transmural LGE, is linked to a significantly higher mortality risk, about 4-fold.
Wow. And ECV, since it quantifies amyloid load.
Exactly. Higher ECV is an independent predictor of worse outcomes. Native T1 is also prognostic, but ECV seems a bit more robust after adjusting for biomarkers. They capture slightly different aspects of the tissue changes.
And CMR can look outside the heart, too. Liver ECV.
Yes, in AL amyloidosis, hepatic ECV, reflecting liver amyloid load is also independently prognostic, even after accounting for cardiac factors and other markers.
What about the bone scans for ATTR-CA prognosis? Does the degree of uptake matter?
That's still unclear, honestly. We know any cardiac uptake, perigeny 0, is worse than none. And a heart-to-contralateral ratio above 1.6 predicts worse outcomes. But studies haven't shown a clear survival difference between grade 2 and grade 3 uptake in established CA. We need more research on quantitative measures like a heart-to-whole body ratio or SUV from SPECT.
And the PT tracers. Any prognostic data?
Some early data, mainly in ALCA. Increased myocardial PIB uptake was linked to worse prognosis. RV uptake of 18F florbetapir was linked to major cardiovascular events. But again,
investigational. Need more data.
Exactly. Still need larger studies to see if they add prognostic value beyond our established staging systems.
Okay, so biomarkers combined with advanced imaging give us the best picture of prognosis. Now let's talk treatment, starting with the exciting developments in ATTR-CA.
Yeah, this has been a revolutionary area. Until recently, it was all just supportive care diuretics for volume, managing symptoms.
Some studies now show potential benefit from low-dose beta blockers in patients with reduced EF, MRAs, even SGLT2 inhibitors, but none of those target the actual amyloid process.
Right. The big news is the development of disease-specific drugs, thanks to a better understanding of the pathophysiology. We have multiple options now, approved or in late-stage development.
Which raises the question, how do we know if treatment is working or if we need to switch or add therapies? The review mentions this lack of consensus.
It's a key challenge. We need reliable markers of progression. One large study found that NT-proBNP increases specifically Over 700 NGL and rising more than 30% and needing more diuretics were independent markers of worse prognosis.
And functional measures, like the 6-minute walk test.
Yes, a decline in 6-minute walk distance, either an absolute drop over 35 meters or a relative drop over 5%, also flags progression and worse outcomes. Table 2 lists some progression markers.
What about serial imaging, echo?
Serial echoes showing worsening mitral or tricuspid regurgitation or drop in stroke volume have been linked to increased mortality. Imaging endpoints are becoming much more common in clinical trials now.
Makes sense. Okay, let's break down the ATTR therapies. First, TTR stabilizers. How do they work?
They bind to the TTR protein tetramer, stabilizing it, preventing it from breaking apart into those unstable amyloid-forming monomers.
Diflunisal.
Limited data specifically in ATTR-CA, mostly used in neuropathy. Small retrospective studies hinted at reduced mortality. Some imaging studies suggest it might slow progression-stabilizing strain, for instance.
Tafamidis, that's a big one.
Huge. The ATTR-ACT trial showed clear benefits, reduced all-cause mortality and cardiovascular hospitalizations. Post-hoc analyses showed less worsening of echo parameters like stroke volume and GLS compared to placebo. Other studies confirm it seems to slow the deterioration in GLS and myocardial work.
Any imaging showing direct effect.
One bone scintigraphy study using SPECT showed that a reduction in tracer uptake, SUV retention index, was associated with favorable biomarker and echo changes in patients on tafamidis.
What about acoramidis?
Another stabilizer. The ATTRibute-CM trial met its primary endpoint using a hierarchical analysis looking at mortality, CV hospitalization, NT-proBNP change, and 6-minute walk test change. A small CMR sub-study showed some favorable trends, even potential amyloid regression in a few treated patients, which wasn't seen in the placebo group.
Okay, moving from stabilizers to gene silencers and gene editing, these target TTR production in the liver.
Right. Reducing the supply of the precursor protein. Patisiran was first, approved for ATTR neuropathy based on the Apollo trial.
Did it help the heart in those patients?
A post-hoc analysis of patients with suspected cardiac involvement showed reduced wall thickness and improved GLS compared to placebo. But the definition of cardiac involvement was a bit loose. The follow-up Apollo B trial in ATTR-CA showed slower decline in the walk test, but the FDA didn't approve it for the CA indication, citing a small effect size. Some small imaging studies do show reductions in NT-proBNP, ECV, and tracer uptake in some patients on patisiran, but we need bigger studies.
Vutrisiran, similar mechanism.
Yes, another RNAi therapeutic subcutaneous injection. The Helios trial showed efficacy in neuropathy. Again, a post-hoc analysis suggested benefit on cardiac parameters versus historical placebo, but with study limitations. The main cardiac trial, Helios B, just reported positive results showing reduced mortality in recurrent CV events.
And eplontersen?
Another gene silencer, antisense oligonucleotide. NeuroT transform trial positive for neuropathy. Again, post-hoc echo analyses versus historical controls suggested cardiac benefits, but with limitations. The big ongoing trial is CardioT Transform, specifically in ATTR-CA, looking at heart outcomes and using serial CMR, including ECV changes.
Then there's gene editing with CRISPR-Cas9 and TLA 2001.
Yeah, cutting-edge stuff. Phase 1 showed safety in deep sustained TTR knockdown. The Phase 3 Magnitude trial is now underway in ATTR-CA, also looking at heart outcomes and using serial CMR with ECV.
Finally, therapies aiming to remove existing amyloid, anti-amyloid therapies.
This is the holy grail, really. There was proof of concept from a few patients who developed spontaneous antibodies against ATTR. They had a remarkable regression of amyloid on imaging and functional improvement.
So antibody therapies are being developed?
Yes. NI-006, now called ALXN2220, is an antibody. Phase 1 showed safety and hints of disease regression, lower biomarkers, lower ECV at higher doses. A Phase 3 trial is planned.
Any others?
PRX004, or coramitug, is another antibody. Phase 1 seems safe, and early data suggested echo improvements in GLS, but full results are pending. And AT02 binds multiple amyloid types, aiming to boost clearance by macrophages. Phase 1 ongoing, using CMR ECV as an endpoint.
Wow, lots happening in ATTR-CA treatment. Table 3 in the review provides a great summary of all these drugs, mechanisms, status, outcomes. Now, what about tracking treatment response in ALCA? The approach there is different.
Very different. Mainstay for ALCA is cytotoxic chemotherapy to shut down the production of those toxic light chains by the plasma cells.
So response is assessed primarily by blood tests, free light chains.
Yes, hematologic response reducing the FLCs is key. But we also look for direct cardiac response. NT-proBNP changes are widely used, but they can be influenced by things other than just the heart amyloid.
So imaging comes in again as an adjunct.
Exactly. Multimodality imaging is important for non-invasively assessing changes in the actual amyloid burden in the heart with treatment. And this is becoming even more important as therapies targeting existing fibrils like anselamimab and berdomab are being developed for AL. We need imaging to see if they're working.
What does imaging show? Echo GLS.
Small studies showed GLS improvement correlating with hematologic response.
Right.
A larger prospective study confirmed this and found that a clinically significant improvement in GLS, defined as 2% or more, was independently linked to better survival. GLS change was even used as an endpoint in an anselamimab trial, showing improvement.
And CMR, especially ECV.
CMR lets us track changes in tissue composition. ECV acts as that surrogate for amyloid burden change. A key prospective study showed that in patients with a deep hematologic response to chemo, some showed regression of ECV.
Before structural or functional changes.
Yes, suggesting the clearance of amyloid can start before the heart structure visibly improves. It also suggested that hematologic response alone isn't enough. Intrinsic clearance mechanisms matter too. ECV reduction tended to precede improvements in systolic function and LV mass. And importantly, ECV change was independently prognostic, even after accounting for hematologic response. Figure 7 visualizes this.
Can CMR track response in other organs in AL?
Yes, multi-organ ECV can track liver and spleen response, correlating well with SAP scintigraphy and organ biomarkers. Regression rates varied visceral organs, often cleared faster than the heart. And visceral ECV changes were also prognostic, particularly hepatic ECV change. Serial CMR seems safe and useful for this multi-organ tracking.
What about native T1 for tracking in AL?
Serial native T1 also tracks cardiac response. Reductions are linked to favorable changes and better prognosis. Remember, native T1 reflects both amyloid burden and potentially edema or inflammation.
Any hints from P tracers for tracking AL response?
Early days. One small study suggested higher 18F fluorobetapure uptake in active ALCA versus patients in remission. But we really need serial PET studies correlating changes with other markers and outcomes.
Okay, looking ahead now, future perspectives. CA is being recognized more, diagnosed earlier, but still many late diagnoses.
Unfortunately, yes. Despite progress, late diagnosis is still a major issue. Awareness is better, diagnostics are better, therapies are emerging, but we're not catching everyone early enough.
So things like screening programs, using AI on routine echoes.
That's a huge potential area. Automated algorithms applied to the millions of echoes done routinely could flag potential cases much earlier, allowing timely workup and treatment initiation.
AI could also improve measurements, make them more reproducible for tracking.
Absolutely. AI could enhance diagnostic accuracy and provide precise, reproducible quantification, helping us track those subtle changes over time with treatment.
And that ability to track amyloid burden change is critical now.
More critical than ever, with disease-modifying therapies available and amyloid removal therapies in development, we need reliable ways to see if these drugs are actually reducing the amyloid load.
CMR mapping seems promising there. PE, too.
Yes, CMR with multi-parametric mapping, especially ECV, is showing real utility. PE, and potentially other tracers, look promising for serial studies, too. We need more head-to-head multimodality studies to figure out the optimal way to track changes precisely over time.
So to wrap up, cardiac imaging has really transformed the landscape for cardiac amyloidosis.
It truly has. Diagnosis, prognosis, understanding the disease, monitoring treatment, imaging is central to all of it.
Techniques like multi-parametric mapping give us incredible insights, non-invasive measures of amyloid burden, allowing us to actually visualize the impact of treatment, see regression.
We can understand how the heart muscle responds. Tailor treatment, it's moving towards more personalized medicine for CA.
And the next frontier seems to be AI integration.
It's like it. Leveraging AI for automated analysis, improving accuracy, improving precision for tracking response that could lead to even earlier diagnoses and better management.
It's a rapidly evolving field. The continued development and smart application of imaging will undoubtedly keep improving outcomes for patients with cardiac amyloidosis.
Absolutely. Exciting times despite the challenges.
So that brings us to the end of this deep dive. Thanks for joining us. Remember to subscribe on Spotify and YouTube.
Thanks for listening.